would like to thank IDA, I would like to thank Shanti ma'am for this session and Erin ma'am for chairing our session. And again, thanks to all the delegates and my friends who are here for my session. So my topic is for this is actually how to do a bad root canal, and I've correlated the simple thing that is kabhi khushi, kabhi gum, that is kabhi RCT, kabhi gum, because since the time I have become an endodontist, a lot of khushi has gone, lot of RCTs have come, but every RCT comes with lot of sadness. There can be flare-ups, there can be trauma cases, there can be repetitive pains to patient, and thus I have tried for a concept, that is how to do a bad root canal. If we can do reverse engineering, if we can learn what is actually bad, we can actually move what is more better or more nicer to do. So welcome to Indore, to everyone who's from outside. As Indoreans, we love definitely Zakir Khan, who is from our local boy, he's a stand-up comedian of a global level. We love poha jalebi. Unfortunately, it was not there in the menu. I hope it is there tomorrow in our breakfast menu. And we love Sunday morning greetings. We also love NRI patients who come in December and January to Indore, America se, Canada se, New Zealand se aate. What is the biggest problem? They come with a strict timeline. We have 3 days. We have a RCT to be done, which was told to a doctor in USA 6 months back or 12 months back, and we want an immediate crown. What do? Our brain starts to work. First thing which we need to do, we make the patient wait outside. Then we call our lab wala. Crown kitni der mein dega? Not days, kitni der mein. Because we need to do a hurried root canal, we need to deal with the crown. All our focus goes onto the crown, the prosthesis, because that is the money-making thing. And we skip the important step, that is the endodontic treatment, because we are in shortage of time. So we come down to the conclusion, that is dentistry is doing root canals in tough cases, but eventually it comes down to extracting of the same hurried or badly done root canals. We also have a lot of sadness. If you are a cricketing fan, you will always remember this state 2 years back. We'll have more sadness. We have back pains, we have finger pains, we have neck pains. At the end of a day, every dentist has a bad back pain if you are into practice for more than 2 or 3 years. Then we have bad cases like this. Curved canals. We have canals of premolars which are straight. Then how we can get rid of our sadness? Again, if you follow cricket, we all know there is a national hero who can take away our sadness. Again, in this winter season, we can have a good cocktail night tonight, and I hope this is on the menu. And then we have a national painkiller. Whenever a patient asks, I have got a root canal done or I want to get a root canal done, even before knowing him or her, we just say, 2 Kiderol khana, aa jana. या ट्रीटमेंट करा के जाओ और 2 Kiderol खा लो. So what is a bad root canal? Any bad root canal is something which has a short obturation, separated instrument, missed canals, or multiple things. We can have failure at the level of access opening or even access filling. We can even have failure on the level of diagnosis or even failure to anesthetize the tooth properly. So what is the pathway of having this sadness of doing a bad root canal? We can have improper diagnosis. We can have improper diagnosis and radiology, and not understanding what is the long term, the longevity of any tooth. We can have improper case planning, whether we need to go a single sitting root canal or a multiple sitting root canal. We have improper PMP and observations, and we are doing more of a patient-oriented treatment. Like I just mentioned, the patient coming from outside who gives us a strict timeline. Then, what can be one level of failing a root canal? It can be sterilization. The most important thing is sterilization, which we are studying from BDS first year. That how important is to maintain sterilization and cross infection in any process, in any dental process. Then comes diagnosis and radiology. We have 4 important pillars which we want to focus. First is the X-ray, the radiology. Then we need to understand the clinical symptoms of the patient. There can be radiating pain, there can be space infections, there can be multiple big lesions involved, or case of anterior trauma where the lesion is actually spreading into the bone. Then we can have perforations of maxilla to mandible or mandible to maxilla. Then we can have periapical and PDL issues. So to start with radiology, always take multiple X-rays with multiple angulations. What seems straight is not straight. If we go on to angles, we can actually make out that no tooth has single canal. It can always have multiple canals. If you see in the first photograph, it is a single molar. You can go for a single canal, but as you take multiple X-rays, angulated X-rays, you can make out that what is the importance of angulated X-rays. If you see this molar, on a proper 2D X-ray, it seems a simple lower 4-6. But as we dive deep into radiology, it is a case of a radix with an extra root. If we take the help of advanced radiology, that is, we go with the CT, we can actually see that how there is a lesion with the distal root, which was actually not so evident in the 2D. So we can have failure at the level of PMP, that is filing and irrigation level. Firstly, we need to understand the canal length and never do it with a single method. Always have tactile, apex locator and RBG. A collaborative effort of all will only lead to a good treatment. Then we need to understand canal diameter. That what is the canal diameter? All we talk about lengths, 20 mm, 21 mm का length है, 25 mm. We always forget that our body is a three-dimensional object. The root canal is actually a well, it is an ice cream cone. So we need to give importance to the diameter. And then comes hand filing and rotary filing. Then we need to respect the apex. We always need to respect our apex because what we see on an X-ray is a radiographic apex. But what actually the apex is an anatomic apex. So we need to understand that there is a margin of error of 0.5 mm to up to 1 mm or at times 1.5 mm between the radiographic apex and the anatomic apex. Then again canal diameter. So we need to gauge our canals. To avoid failures, to avoid doing a bad root canal, you need to gauge, you need to understand कि मुझे कहाँ तक prepare करना है. By seeing the X-ray, by doing the initial filing, you can actually make out that what can be the final circumference of your final preparation. We are only focusing on lengths from past few years, but we need to understand the diameter. Then we need to understand what are the age-related changes. You go on to a senior citizen patient, you will have calcified canals, you will have a narrow apical diameter. And then finally comes how much percentage of a root canal is actually clean. Even the best endodontist in the entire world claims that any root canal is clean less than 50%. Because there are so many anastomosis, there are so many lateral canals that no one can make out the entire cleaning of the root canal system. So again continuing with the canal diameters, what if we over prepare a narrow canal? We have a very narrow slender canal. What if we do it over preparation? We'll have apical perforation or separation. So we need not do कि आज मैं नया फाइल सिस्टम यूज किया, इसे बहुत बार चलाऊंगा, बहुत बार घुमाऊंगा. Ultimately we lead to strip perforations. If we are doing under instrumentations, we'll have incomplete debridement or we'll have no deeper inner preparations. So always remember to avoid doing a bad root canal. If there is a longer root, it is a slender root, go for 4%, that is in narrow canals. In wide canals, go for 6%. Here are the examples where we can see long and slender roots and we can see thick distal root which have 6% obturation. Then comes role of local anesthetic, which is very important and it is very overlooked. If you can anesthetize your patient well, he or she will cooperate, you will be free to work easily. So never underestimate the use of local anesthetics. You can actually now have good anesthetics, that is articaine, or you can even have substitutes of lignocaine as Lignox. Then comes something called as hot tooth, which I have called as dentist vacation tooth. Whenever you are not at your clinic, always एक पेशेंट का फोन आएगा जिसको आपने 6 या 12 महीने पहले कभी ना कभी बोला था कि आप आरसीटी करा लो या फिलिंग करा लो, पर जिस दिन आप बिजी हो, आपको शादी में जाना है या आपको वेकेशन पे जाना है, उसका फोन उस दिन जरूर आएगा कि टुडे आई एम रेडी बिकॉज आई हैव सिवियर पेन. What we do in such cases, whenever you have a hot tooth, the patient will always come with a history that he or she is drinking water and getting relief from pain, but as soon as the water drains out from that tooth area, there is severe pain. Mostly it is found in lower molars, and if you ever have a hot tooth to operate, then go for a multiple anesthetic approach. That is the one which I mentioned in the last line. You can have an iron block, you can have a buccal infiltration, local infiltration. At times you can have mental nerve block as well, because there are some sensory innervations from the premolar side coming to it as well. Still after having hot tooth or certain tooth, definitely there is no logic in that. And then comes to our rescue, that is Peterol DT. I am no ambassador of Peterol DT, it is just for fun. Then lastly comes flare up. Whenever we do a hurried treatment or a bad treatment, we know that it is going to convert into a flare up. It can be either a mid-treatment flare up or post-treatment flare up. Initially, we will definitely hear out the patient, but when we are not able to, ultimately we come down to certain things. Mid-treatment flare up can occur when we have failure to debride our root canals, when we have failure to establish a proper treatment planning before starting the treatment, then we are not giving enough time to healing of the PDL ligaments or the abscesses, and we are hurrying in our root canals. What is the treatment? Most important is patient assurance. If you can assure the patient, if you are confident on yourself, definitely the flare up will come down. Steroid dressing and oral steroids is another thing, and then you can rectify the mistake at canal level, that is debridement and irrigation. You can even have flare up by irrigations. At times you can actually push the irrigant, hypochlorite or even chlorhexidine beyond the canals. That happens if we are using open end syringes. So we can go on side vent syringes in these cases. And if you have ever the incident of a flare up by a hypochlorite injection, then what you need to do, you can actually anesthetize that area again, flush with saline, and then just abort and medicate. Now, finally, if you have a post-obturation pain, you have done everything right, then it is very normal to have a post-obturation pain on that day, or studies also say to up to 3 to 5 days. It is very normal. You can check for high points. Why this pain happens? Because we are actually filling with gutta percha, with sealer, we are irrigating. Whenever a foreign material goes inside, such things happen. So it is normal. You can check for high points. You can check for the pressure occurring due to the access filling. Even if everything is alright, all points are covered, then this must be our go-to mantra. So in the end, let's summarize the failures. It can occur at the level of diagnosis, at the level of access opening, canal searching, scouting, negotiating, anesthetize, interappointment dressing failures, separation failures of instrument, failure to isolate, all the processes failures, armamentarium failures, that is using overused files, illumination is not proper, and then rush treatments.